Hi, I'm Manuel Lentzen from Frauen for Sky, and I represent our project Transform-Based Risk Models for COVID-19 disease progression. The motivation for this project is the COVID-19 pandemic. Situations like this can put the healthcare systems under a lot of stress. Patient-level risk models can help identify patients with a high risk of severe disease progression so that available resources can be used more efficiently. Here we used existing medical records from EHRs to develop risk models and predict the risk for specific endpoints. The work is split into three parts. First, I will speak about the self-supervised pre-training of the transform-based model Med-BERT. Then I will talk about the development of the risk models. And finally, I will speak about the model interpretation part. First, I want to spend a few words on the transform-based model. Transform-based models originate from natural language processing, but they have been applied to other areas in recent years. One example is the Med-BERT model, which was already developed for structured EHR data, and in this project we extended this approach. We modified the embedding layer and included information about a patient's diagnoses, drugs, sex, date of residency, age, and visits. And this information was then all combined and passed through transformer layers which were left unchanged. Regarding the data, we had access to the IBM Explorer's therapeutic dataset. We filtered for patients with at least 5 observations and ended up with approximately 3.8 million patients and 700 million records for pre-training. We used the same hyperparameters as in the Med-BERT model and masked language modeling and the prediction of long hospital stays as training objectives. Masked language modeling is the prediction of masked diagnoses and drugs based on the contextual information, and the prediction of long hospital stay is the task of predicting if a patient was hospitalized more than 7 days during any point of the medical history. On the right you can see the pre-training metrics. In the end, we had a +1 score of 66% and a masked language modeling accuracy of 67%. In the next step, we used the pre-trained model to develop the risk models for the COVID-19 disease progression. We focused on patients with acute respiratory manifestations in 3 weeks following the COVID-19 diagnosis, and we fine-tuned our model with 3 classification heads for the binary classification task. Namely, we used a feed-forward network, LSTM, and gated recurrent unit. These models were then compared to baseline models, random forest, and XGBoost, and the plot on the left shows the ROC curves, the plot on the right the precision recall curves. One can see that the Med-BERT models all perform very similar, if not identical, but they are several percent points better than the baselines, and based on the precision recall curve on the right, you can see that there's a slight difference, and the Med-BERT model with the feed-forward network is the best one in this example. As a final step, we wanted to interpret our models. We focused on the integrated gradients approach to identify the most important features, and then used the Bayesian networks to understand the relationships. The integrated gradients method is a method that can calculate an attribution for each input element with respect to the model predictions. This plot here shows all calculated attributions for the top 20 diagnoses and drugs. If most scores that you can see there on the right side of the blue line, that indicates a positive attribution, and vice versa. If you look at the most important features, you can find something like shortness of breath, type 2 diabetes, chronic airway obstruction, and also several more known risk factors for COVID-19. But there are also some drugs which are less clear to understand, and here we had the possibility to look at Bayesian networks, which were inferred for the top 100 features, and the next slide shows one example. On this slide you can see the direct neighbors of the example drug Dihydropyridine derivatives in the inferred Bayesian network. The drug itself is, as shown, related to essential hypertension, similarly for angiotensin II receptor blockers, and alpha and beta blockers as well as platelet aggregation inhibitors are often prescribed for people with heart disease. So this shows that the strong impact of this dihydropyridine derivatives on the model's prediction is reasonable. And now to conclude from all of this. We successfully trained a new transform-based model for structured EHR data. We used it to develop risk models for the AM endpoint, and they outperformed XGBoost random forest. In the final step, we identified several known risk factors as important features for our models using the integrated gradients approach and Bayesian networks. With that, I'm finished, and I want to thank you for listening. If there are any questions, please write me a message.